What do you think?
Agree.
Okay. Okay. So thank you everybody for joining in. So today we're having our third session of Virtual Visiting Professor. We have our expert, Dr. Scott Eggener, who is a specialist in oncology and who does a lot of prostate cancer cases in the US. So let's welcome Dr. Scott Eggener for this session that we want to be interactive, meaning that you can ask questions as we go and we can interrupt some time and we can reserve some other question for the end. Also, let's remind ourselves to shut our microphone to avoid some noises as we go. So thank you again, Dr. Eggener, and you have the floor.
Great. Thanks, Dr. Jallo. And hello to friends and colleagues from wherever you are, and best wishes to you during these unique times. I'm happy to talk about anything related to prostate cancer. Dr. Jallo had mentioned an interest in some slides about screening and biomarkers and MRI. I have a lot of slides, but I'll try to keep it relatively short for each slide. And then, as Dr. Jallo mentioned, please send questions via chat at any point about anything, and I will do my best to answer as best as possible. So here comes my screen, and hopefully everyone can. Can everyone see okay?
Yes, we can see the screen.
Great. So I'm in Chicago, and most of my clinical and research practice is in prostate cancer. We're going to talk about earlier stage disease. Obviously, the setting in the United States is very different than in many other settings where you deal with more advanced disease at the time of diagnosis. And I'm happy to discuss that at the end on how we deal with high-risk disease or metastatic disease. But at least in the United States, the way I look at PSA screening is there's the good, the bad, and the ugly. The good is, since we've instituted PSA screening in the United States in the late 80s and early 1990s, there's 50% fewer men dying of prostate cancer, and that's great news. But the really bad news, as you're aware, is that there are literally millions and millions of men who were diagnosed and treated for prostate cancer, and they never needed to know about their prostate cancer. And the ugly is, you know, the physicians have historically been part of the problem. We were screening everybody, we were biopsying everybody, we were treating everybody, and we just need to be smarter and more sensible about it. And biomarkers and MRI are a way that we have improved, but part of the problem is they're very expensive. So like I mentioned to you before, 50% fewer men dying of prostate cancer since the late 1980s. And the great news is the greatest benefit has been seen in Black men in the United States, the greatest drop in mortality over the last 30 years or so. So I absolutely believe that PSA screening, when done smartly, can save lives. But we have a phrase in English called the elephant in the room, which is something we hadn't talked about for a long time, but we should be talking about, and that's the problem in the United States of over-detection and over-treatment. And this is the root of the problem. This is a very famous study from 25 years ago. These were all men that died of other causes. They never knew about prostate cancer, but on their autopsy, they dissected their prostates, and shockingly, at ages even as low as 20s and their 30s, there were high rates of prostate cancer. So you can basically take your age as a man, add a percentage after it, and that's the likelihood that you have histologic prostate cancer in their prostate. Now, in the United States, only 3% of men are going to die of prostate cancer. So there's a tremendous number of men that have prostate cancer that never need to know about it. These are the screening studies that were done with PSA, and we're not going to go into all of the details. The two biggest are the US and the European, which you're hopefully aware of. And I'm just going to hit some high and low points of them. And I'm obviously happy to share these slides with you if you want, or we can, in the question and answer session, we can go into more details. The United States trial was called the PLECO study. And the PLECO study was a garbage study. And the main reason is 90% of men in the control arm, the men that weren't supposed to get a PSA, ended up getting screened. And that's just a huge problem. And that's why when they analyzed the study, there was no difference in death rates between the two arms. Moving to Europe, they did a better job. And in general, this was countries putting their data together. Some screened more rigorously, some loosely every 4 years. But as you followed men out, starting at about 7 or 8 years, you can see the death curves diverging. And the control arm, meaning no PSA, had a higher rate of death. But it was still a relatively modest decreased risk of death, only 21%. If you look at country by country, right here was the wide difference in mortality reduction. Some only had a 5% reduction, some had a 40% reduction. And it was very humbling when you look at it, the number of men you needed to invite for screening to save one life was measured in the hundreds or thousands. And the number you needed to diagnose and treat to save a life was from 12 to 30. Now, the single best country for doing the study was Sweden. And the reason for that is they had 20,000 men screened every 2 years. They had a relatively low threshold for a biopsy, very long follow-up, and importantly, the control arm did not get screened. So if they were randomized to no PSA, they in general didn't get a PSA. And what you saw is in the men that got a PSA, there was about a 40% lower likelihood of death from prostate cancer. But let's remember, if you take a population of men, the overall death rate from prostate cancer is really low. So it looks humbling when you go from 1.5% down to only 1%. But a critically important point is of the guys that were diagnosed, nearly half of them didn't have immediate treatment. And we are now, I've been a huge fan of active surveillance for prostate cancer for about 10 or 15 years, and it is becoming more popular and more appropriate in the United States. If you look at PSA testing compared to other things that are done in medicine, and you look at the number needed to screen to save a life, or the number needed to diagnose to save a life, it's on par with mammography, colonoscopy, hyperlipidemia screening, and hypertension screening. One thing we had to really drill home to doctors in the United States is not every man needs a PSA. So this was a study that we did many years ago, but it was really disturbing to see the likelihood of getting a PSA for men in their 70s and 80s, men who are really unlikely to benefit from screening, but they were far more likely to get a PSA than guys who were younger and healthier and more likely to have their life saved. I put these pictures up here. Age is but a number, okay? I am way, way more interested in what we call physiologic age, which is how healthy a guy is and how much longer he's gonna live. You saw from the European study, the benefit of screening didn't really come into play until 8, 10, 15 years down the road. So this is a 50-year-old man who I think it would be crazy to check a PSA. These are actually men in their 80s. Now, I don't think it should be common to screen men in their 70s or 80s, but if you have a very healthy 70-year-old man who's going to live another 20 years, I think it's perfectly reasonable. This is data we have in the United States on how when a man reaches a certain age, the likelihood of him living to additional ages. So when a man reaches 77 in the United States, that's when his life expectancy drops below 10 years. But you obviously need to tailor this to your own region. These are the AUA guidelines. We should never be screening men less than 40. Up to age 54, no routine screening unless there's a strong family history or if there's a known genetic risk factor like BRCA1, BRCA2, ATM, or others. For men age 55 to 69, not every man should be screened. It should be a discussion on whether it's smart and sensible and whether he wants to. And then when screening starts, every 2 years is reasonable. It does not have to be done every year. And then I'm going to show you some data on baseline PSA level. The first PSA level can help dictate whether the man should be screened every 1 year. We also have a large national organization called the NCCN, and I like these better than the AUA. And this gets to what I mentioned earlier, where your PSA level at baseline, if it's really low, check it again in 2 to 4 years. If it's mid-range, 1 to 3, you repeat in 1 to 2 years. If it's high, then you repeat it and consider a biopsy. I think there's a lot more nuance that can go into this decision. Obviously, it's very different if your age is 45 or 75. It also depends on how large or small the prostate is, what your PSA density is, and your family history. And then in our guidelines, there are consideration for biomarkers and MRI, which I'm going to talk about a little bit. The free PSA is a very powerful component in addition to the total PSA. Some places have a prostate health index, which is a combination of 3 types of PSA. It's free PSA, total PSA, and pro PSA. And then the 4K score is a test that we have available, which is 4 kallikreins. PSA is a kallikrein, and I'll go over some of the data on that. But it's really important to remember there's no such thing as a normal or abnormal PSA level. It's like asking someone what's old or not old. You can't say, oh, if you're over age 60, you're old, and if you're under age 60, you're young. This is great data from a huge trial that was done of tens of thousands of men. And even men with really low PSAs do have a risk of prostate cancer and having high-grade disease, but it incrementally increases as the PSA goes higher. I would strongly encourage you to factor in a man's age, family history, total PSA, if you have free PSA, if you can consider PSA density. Always repeat a newly elevated PSA. I don't think a man should ever have a biopsy based on one new increased PSA, and we always just repeat it a couple months later. This is an old study, but a really important and really good one. These were nearly 1,000 men that had PSAs checked, and then they were checked a year or 2 later. And if it was abnormally high, about half of them, it returned to normal at the next visit. And that next visit might have been 1, 2, or 3 years down the road. So as you know, PSAs can bounce around a little, and we can avoid a lot of unnecessary biopsies just by repeating the PSA. There was a time in the United States where we gave men a lot of antibiotics for an elevated PSA. They would come in, their PSA was high, you'd say maybe there was some subclinical inflammation or infection. If you think they have an infection, prove it on a urine culture and absolutely give them antibiotics, but don't give empiric antibiotics. We did a randomized study on this where half the guys got empiric antibiotics, half didn't. And what this table shows you is whether they got antibiotics or not, their repeat PSA level was exactly the same. So there was really no advantage, and that was 2 weeks of antibiotics. Other people have done studies with 6 weeks of antibiotics. And it's incredibly important not to give someone antibiotics when you may be considering a biopsy and increasing their likelihood of infection. Here's the data that I mentioned on baseline PSA level. Really powerful information. Somewhat of a confusing figure, but I'm going to walk you through it. This is data from over 20,000 men in Sweden, men in their 40s. So they were all less than 50 years old. The gray here is the distribution of their PSAs. As you'd expect, almost all of the men have a PSA less than 2. But even at this very, very young age, if you follow those guys for decades, that early PSA level does predict the lifelong likelihood of developing a palpable cancer, which is the red line, or an advanced cancer, which is the black line. And the two reasons for that are, as we know, prostate cancer often develops over many years and decades. And so you can identify it early, but also when you have men in their 40s, they typically do not have any BPH or inflammation. So the PSA is a more accurate reflection of cancer production rather than a noise or getting obscured by BPH or inflammation. Swedes have also shown that age 60, there's some data I would take your attention right here. If your PSA is below 2 at age 60, there was no measurable benefit in continuing screening. So you might be able to stop screening. But if your PSA is greater than 2 at age 60, screening saved a lot of lives. And the number of men that were diagnosed to save a life is 6. And that's as low of a number as you're going to see. You remember from earlier in this talk, in those big screening studies, that number needed to diagnose to save a life was much higher. In the United States, we need to learn to when to stop screening. And back to Sweden, I showed you some data. Sometimes if your PSA is less than 2 at age 60, and certainly if your PSA is less than 1 at age 60, because in their data set, if your PSA is less than 1 at age 60, by the time you're 85 years old, the likelihood of dying from prostate cancer is less than 1%. So here's a summary slide of some of the things we've talked about, at least in the United States and many other countries, where we're trying to keep the benefits of screening, of saving lives, but minimizing the unnecessary biopsies, unnecessary treatments, and unnecessary side effects of treatment. Before we move on to some biomarkers and MRI, I'll turn it over to Dr. Jallo. Any questions or comments?
Thank you. I'm Dr. Hassan Dogo from Nigeria.
Yeah, go ahead.
We usually have very huge prostates. And when you do the PSA, you find out that the PSA ab initio is high, it's even high. So such PSAs, they usually never come. So what is the role of PSA velocity and density in managing this kind of elevated PSA?
It's a terrific question. So I took out some slides on PSA velocity. My personal opinion on PSA velocity, there's been 2 really well done large studies in the United States and Europe suggesting that PSA velocity by itself does not help predict the likelihood of prostate cancer once you already know the total PSA, the age, the DRE, and the family history. So I do not routinely incorporate PSA velocity. However, I am a huge fan of PSA density, and I'm going to show you some slides upcoming showing you the power of PSA density. And the other thing that we have access to, and many of you might, is MRI is often helpful for those really large prostates. If their PSA is high, if their free PSA is low, if their PSA density is concerning and high, An MRI can be useful, and if the guy has a huge transition zone, a very small peripheral zone, and no concerning lesions, I will often just monitor that guy and not do a biopsy.
Okay.
Thank you, sir.
I would like you to come back to the comparison between the European study and the Swedish study. In the first one, we had a 21% drop compared to less than 1%. So, I mean, what would we expect to say that the screening is significant? Is it just the percentage, or what are the other confounders that needed to be taken into account?
Yeah, the European study were many different countries put together, and each country had different screening frequencies, PSA thresholds for a biopsy, different follow-up, which is why you see decreases in the death rates that are quite variable. But to your question, that's the difference between the absolute difference in death rate versus the relative reduction in death rate. So if you tell someone in Sweden, we're going to screen you, and there's a 40% lower likelihood you're going to die of prostate cancer, that sounds really exciting. And most men will say, yeah, I want to lower the likelihood by 40%. But you can tell that same man the absolute likelihood of him dying of prostate cancer was 1.5%. And then if we screen you, it'll go down to 1.0%. And so the absolute reduction is only going to go down 0.5%, a 1 in 200 chance. And he might say, why would I want to do that? So it's all how it's presented. And that's the difference between absolute reduction and relative reduction.
Okay. Thank you. The other question is related to African American, the drop in mortality. I know I'm mentioning them because they're the closest to us African because of genetic background, etc. So how do you explain that? Is it because of treating them early in the setting of more aggressive disease, or how do you explain this drop?
The short answer is it's very complicated and we don't know. It's good news and it's a true observation. There's obviously a lot of debate on why men with African ancestry seem to have higher likelihoods of developing prostate cancer or dying of prostate cancer. There's certainly some genetic and biologic contribution, but there's also potential differences in the United States and elsewhere with their quality of care, their access to care, and where they're treated and who they're treated by. I've been very encouraged in recent years to see data that men of African ancestry, when you control for where they're treated, who they're treated by, they do just as well as anybody else of any other ancestry. And if they have low risk disease on surveillance, they do really well and there's no differences. If they're treated with surgery or radiation, they do just as well. And so quite frankly, about 25% of the men that I see with prostate cancer are African American, and I don't treat them any differently based on their African ancestry, based on any biologic concerns. Now, if I'm concerned for other reasons, I may change the conversation.
Okay. Thank you. The last thing is a request. We would love you to share the studies about high PSA and antibiotic, how it works afterward. Because in our practice, we believe that, especially when you do the DRE and you find a painful prostate, that any increase might be related to prostatitis or something, and even if the urine culture is negative. So it's a good thing that we consider because we prescribe a lot of antibiotics. So this evidence will be helpful.
So we used to do the same a lot. And then when these randomized studies came out with either 2 weeks or 6 weeks of antibiotics, And when you repeat the PSA, it was no different based on whether you got antibiotics or no antibiotics. So I think it's dangerous to give someone antibiotics if there's no infection. I do think you should do a urine culture. And if you think they have inflammation based on their exam or their symptoms, I would say give them maybe a week or two of anti-inflammatories. So, you know, we use ibuprofen or naproxen. I don't know what you have available there, but that works on the inflammation rather than any bacteria.
Okay. Thank you.
All right, there are a lot of other biomarkers available, and I didn't want to spend a lot of time on the ones that are expensive, but I do want to talk about this since it's come up a couple times. PSA density, incredibly useful and valuable, and obviously free. You know, if you do an ultrasound or if you use your finger to just estimate it, I use this on almost every patient. And this study was over 5,000 men going for a biopsy. And if you look at the gray here, this is their distribution of PSA density. Most men have a relatively low PSA density, but some have a higher PSA density. And it's really, really powerful. This is their likelihood of having Gleason 7 or higher. Directly correlates with their PSA density. Benign disease drops dramatically the higher their PSA density. Gleason 6 isn't really impacted by PSA density. So if your goal is to only find high-grade cancer, and that is my only goal of screening, is to find men with Gleason 7 or higher, I don't want to diagnose anyone with Gleason 6. And if I do, I almost 100% of the time put them on surveillance. But PSA density is incredibly powerful. I also use a ton of free PSA. It's really cheap. It's really powerful. So some of the biomarkers that are available in the United States are called the Prostate Health Index or the 4K score. You may have read about them. You may have used them. The single most important factor in those tests that make them powerful are the free PSA. So these curves are somewhat confusing, but the higher that it goes to the left, the more powerful it is. And the red line is the free PSA. And the blue line is the Prostate Health Index. So those are pretty close to each other. Interestingly, the total PSA doesn't work as well as the free PSA. So the total PSA is the gold line here. Same with the 4K score. The single most powerful thing is the free PSA. So I use a lot of free PSA, and the lower the free PSA, the higher the likelihood of prostate cancer. And there's no magic number, but the lower it is, the more concerned I am. All these biomarkers that I'm going to show you, the goal of them is to minimize the number of men who need a biopsy, find the Gleason 7s or higher, and don't diagnose the Gleason 6s. So this is a very long list of tests we have available. Some of them are blood tests, some of them are urine tests, and one of them is a tissue test for men who have had a previous biopsy. The good news for you is I'm not going to go over all of these. I'm happy to discuss any of them. The goals of them are exactly the same as what I just mentioned. Let's talk about the 4K score. It's 4 callicrins. These are all different callicrins. Total PSA, free PSA, intact PSA, and HK2. The two most powerful here are the total PSA and the free PSA. These two here add a minimal advantage. They are helpful, but they're not hugely advantageous. The test takes these 4 pieces of information, combines it with what you give the company on the patient's age, DRE, and whether they've had a previous biopsy, and then you get a report back, and it's their 4K score. And this percent here is the likelihood of them having Gleason 7 or higher if you do a biopsy. And this can be very valuable. If you get a test result that's 1%, 5%, 30%, 50%, you use that information with the man to decide whether to proceed with a biopsy. So that's the good news, is many men can avoid a biopsy. The bad news is it's expensive, and it costs usually a couple $100. Sometimes insurance companies pay for it, sometimes they don't. Frankly, I do not order a lot of these. I use the free PSA, the PSA density, the total PSA, the family history, the DRE. I'm showing you one of the studies that supports the 4K. It was 1,000 men going for a biopsy. 23% of them had high-grade disease on biopsy. And the bottom line is here in bold. If you use the 4K score, 30 to 60% of the men did not need a biopsy, but you still diagnose nearly all of the men that have Gleason 7 cancer. And you can use different cut points depending on the man. Some guys say, oh, if I have a 10% chance of having Gleason 7, I want the biopsy. And other men say, if I only have a 10% chance of having a Gleason 7 or higher, no way I want a biopsy. So before we move on to the last section on MRI, any questions on biomarkers or biopsies or anything else?
Yeah, I have a question about the Gleason 6, because if you look at the risk stratification, is there a chance that a patient is Gleason 6 and have a PSA beyond 10 or a T stage that is higher? That would be like intermediate or high risk.
Yeah, it can happen. It's very rare. So we've done some studies, and I can send them or show them, but Gleason 6, in the era when we were doing a lot of prostatectomies for Gleason 6, we did a study with some colleagues at other institutions, and there were 2,500 men who had Gleason 6 on final pathology after prostatectomy. And the likelihood of it having extracapsular extension was 0.2%. The likelihood of having lymph node involvement is 0%. And I am convinced that Gleason 6, it is literally impossible for it to spread elsewhere, and that there's never been a man who has died from pure Gleason 6 prostate cancer.
Okay.
But it always requires a higher Gleason grade.
Okay. The other thing is that you mentioned the free PSA. Do you use it apart from the setting of looking at the 4K as an individual biomarker?
I use a lot of free PSA. Our clinic tests for it, and I get the results quickly. And it is part of the 4K score.
Okay.
I don't use them both independently.
Okay. Any question from the participant? Cassel, do you have a question?
No, thank you. I'm following.
Thank you.
So the last section on MRI, I could, fortunately or unfortunately, I could talk for an hour on MRI. We have done a lot of research on it. There's some great studies out there, but I kept it short. So some basics of MRI. If you're going to check it after a biopsy, wait 6 to 8 weeks. It is important whether you use a 1.5 Tesla or a 3 Tesla magnet. Obviously, use the highest one you have available at your place. There's a lot of debate on whether using an endorectal coil is helpful or not. We have a world's expert at our place who swears by the endorectal coil. So we're one of the few places who still regularly uses the endorectal coil, with the idea that it gives higher quality pictures. As you probably know from multiparametric MRI, there are 3 main sequences. diffusion weighted imaging, T2, and DCE. People usually get a T1 to rule out hemorrhage or other artifacts. The single most important sequence is the DWI. That has the most power to find high-grade lesions. Size of the lesions definitely matter. If someone has a larger cancer, you're more likely to see it. And the PIRAD score is very different depending on what area of the prostate you're evaluating. I can't emphasize this enough. There's a lot of importance on the quality of the images and which radiologist is looking at them. There are very good studies showing that even at world-class centers with high-quality pictures, if you show those pictures to an experienced radiologist of the prostate or an inexperienced one, you'll get very different reports. So at your center, if you have MRIs, I think the best thing to do is find the 1 or 2 best people and have them read all of the prostate MRIs. The last thing is MRIs in general underestimate the volume of tumor. And this is important for places that do some focal therapy or partial gland ablation. MRI is good, sometimes great, but it's really important to remember it's not perfect. There are many false positives, there are many false negatives, just like any of the tests we have, just like PSA. The PIRAD score is obviously helpful. There are other ones that exist. And like I mentioned earlier, I think it's incredibly important to find a good radiologist, look at your own data if you have that luxury. What about using MRI for screening? MRI of the prostate is very good at some things and not so good at other things. I do think, based on a lot of randomized trials and even some non-randomized trials, that if you do a biopsy using information from an MRI, that it is better than just doing the biopsy without MRI. It improves the likelihood of you finding a Gleason 7 cancer or higher. It lowers the likelihood of you diagnosing Gleason 6. And if you have good data from your institution, some men who have the MRI never even need the biopsy. Now, there's a lot of debate over this. Some people don't believe in MRIs before every biopsy. There's an editorial in European Urology this month on it. I think the data is supportive. What value does a negative MRI have? Well, it really depends on the institution. These are all world-class places in prostate cancer. But if you have a negative MRI and still have a biopsy, at some places there's a 20% chance of finding Gleason 7, and in other places there's a 1% chance. And so that's why I think it's important to look at your own data if you have that luxury. This is from UCLA, a world-class place with excellent imaging. Somewhat of a confusing slide, but the bars that go up is the percent that, these are all men that had MRI and then a prostatectomy. The bars that go up, these were all identified on MRI. The bars that go down were not identified on MRI. So even at UCLA, you can see there's some Gleason 7 and even 8 cancers. 20% of them were not seen on MRI. Same goes with some larger tumors. And so again, that's why it's important to look at your own data if you have that luxury. In general, if you use MRIs and you get PIRAD scores, this should be the likelihood of you finding high-grade cancers. So you can sometimes look at this information on your biopsy data. These are men that have normal digital rectal exams, elevated PSAs, and a PIRADS 3 to 5 lesion. That should be the likelihood of you finding high-risk cancer. Here's one of the best studies that was a randomized study. 500 men with an elevated PSA considering their first biopsy. Half the men just had a standard ultrasound guided biopsy. The other half of the men had an MRI. Some was 1.5, some were 3 Tesla. Some had an endorectal coil, some didn't. We participated in this trial, but it came out of England. If they had an MRI without a lesion, no biopsy. If they had an MRI with a high PIRAD score, they only had a biopsy of the lesion. And the results were published in the New England Journal of Medicine, and there was what I think of as a triple win. First, if you had the MRI, 28% of the men didn't undergo a biopsy. They had a negative MRI. And so even if you were in that MRI arm, only 72% had a biopsy. But even though fewer had a biopsy, you still found more clinically significant cancers in the MRI arm versus the standard arm. So that's win number 2. Win number 3 is you diagnosed fewer insignificant cancers or Gleason 6 cancers if you were in the MRI arm. So that's why I try to get an MRI before every man considering his first biopsy. Not every insurance company in the United States pays for it, but I typically request it. If he has a very abnormal DRE or he has a very high PSA, I oftentimes don't order an MRI. This was another study that was done. This one was in France, and they looked at a lot of data in men undergoing their first biopsy. They all had an ultrasound guided biopsy, and then they all had 3 cores per MRI lesion. And what this study showed is that if you just did an ultrasound guided biopsy, 29% chance of high grade disease. If you only would have done an MRI guided biopsy, 32%. But if you did both, the systematic and the MRI, it goes up to 37%. So it does go up slightly if you take biopsies systematically through the prostate plus from any MRI lesions. Now, lastly, but really importantly, MRI is not very good at determining extracapsular extension. Now, if you have big, bulky extracapsular extension that you can feel with your finger, the MRI is great. But many times, if you're going to be doing surgery on a man and he's clinical stage T1C, has some Gleason 7 or 8, and you want to know during surgery whether to save nerves on the right or left side, oftentimes MRI is not particularly helpful. This was a randomized study, men going to surgery, half got an MRI, half didn't. There was no difference in positive margin rate. A subset analysis amongst men that were T1C did suggest a slight advantage, but not a dramatic advantage. And then lastly, this is a study done from a world-class place. This is from the National Cancer Institute in the United States. They've contributed a lot of useful information on MRI of the prostate. But when they look at predicting extracapsular extension, the accuracy was very poor. So they looked at all these different individual MRI features. But yet, if you look at their accuracy compared to radical prostatectomy, it wasn't all that good. So this is my conclusion slide. And then the good news for you all is I will shut my mouth and I will turn it over to you for any questions that you have about this or anything else with prostate cancer.
Yeah, but your talk is actually very, very, very nice. It's not boring at all.
Good, that's nice of you to say.
Okay. So I had a question regarding the use of MRI. Do you use it apart from the diagnosis, like to assess the disease extension?
I do at times. It can be helpful when, so the reality in my hospital is many men have it before their biopsy. So if they're diagnosed with a high-grade cancer and going for treatment, the MRI already gives us information about their lymph nodes. And so I don't get a CAT scan because it's not needed. The MRI does a good job. If a man has high-risk disease, I will get a bone scan. I have the MRI done prior to the surgery, but for the reasons I mentioned, I don't only use the MRI to help determine whether I'm doing nerve sparing or not. I think there's a lot of valuable information in the biopsy, in the PSA, in the DRE. I will integrate the MRI information, but I always go a little crazy when I hear about a surgeon who says, oh, the MRI suggested extracapsular extension. I always go wide on that side and resect the nerves because I showed you the data that the MRI is not very good at predicting extracapsular extension.
Yeah.
Okay, thank you. I don't know whether CT, sometimes on CT you may see extracapsular extension. Between the CT and MRI, which one is better?
MRI is better head to head. And if the CT scan shows extracapsular extension, you almost assuredly have big, bulky extracapsular extension that you would have been able to feel with your digital rectal exam.
So in our conferences here, there is a huge discussion always between bone scan and MRI. The radiologists saying that MRI is more sensitive for bone extension, and the proponent of bone scan saying that it will be only if you do whole body MRI, and there is always this discussion about that. What is your thought on the bone scanning?
I agree. The MRI is very useful and very good at staging the pelvis, mostly the lymph nodes, but also the bones. And I do think it does do a good job of staging the pelvic bones, although it's relatively rare for low stage disease to go there. But obviously outside the pelvis, the bone scan does an okay job of looking at the spine and the other structures where prostate cancer can go. As you probably have read, in Europe and Australia and in the United States, we are starting to use some more PET scans with either fluciclovine or PSMA, and that is definitely better than bone scan in looking at the entire body, but it's not always approved, it's very expensive, and I cannot get a PET scan for someone newly diagnosed with prostate cancer. I can only get it if they've already had treatment.
Any question from the audience? Yeah.
With regards to the use of the endorectal coil, I don't know, from your presentation, it's like whether you use endorectal or without endorectal coil, the outcome is the same. So is there any advantage of combining, doing the multiparametry, the pelvic coil and the endorectal?
It depends who you ask. So most places around the country do not use the endorectal coil. The main prostate radiologist I work with, who is an excellent radiologist, swears by the endorectal coil and says he gets better pictures, better images, and he's more accurate with the endorectal coil. Patients hate the endorectal coil for obvious reasons. We always order it with an endorectal coil. Most of them are done with an endorectal coil. Some guys refuse the endorectal coil, and some guys get the endorectal coil, but then come to the clinic and say, I am never, ever, ever doing an MRI again unless I do it without the endorectal coil.
Thank you. So I have another question about the prostatic biopsy. We used to do it transrectally, ultrasound. Until recently, we have colleagues from the UK who came and taught us how to do it transperineal because of the limited risk of prostatitis after the transrectal, like after the transrectal. What is your thought about that? Do you do it like perineal or still transrectal?
I think you're more advanced and sophisticated than we are. So we still do most of ours transrectal, but we should be doing them transperineal. And we were in the process of switching over to transperineal right around the time that COVID started. But I absolutely agree with your strategy and the UK people that if you can do a quality transperineal, I think it's great to eliminate the risk of infection.
They also mentioned that that's the best way to approach the anterior part of the prostate, which sometimes...
I agree.
Yeah. Any other question? I think the talk was excellent. I really appreciated it, and I did a very great revision of things that I thought were, very clear. And thank you.
Please let me know if there's other people that want other topics in prostate cancer. I have many other talks on topics. I have friends from across the world that would probably be happy to join with our friends and colleagues in Africa to have an information exchange. So
definitely we'll do. Yeah. So I think
I'm interested.
Yeah. Yeah, if you guys, someone from the audience is interested, just let me know and we'll help put together other talk on demand. Today we expected to have more people, but there is a conflicting other webinars. As you know, everybody is doing webinars, and for today, if we knew, we would do it like yesterday or maybe tomorrow to avoid the conflict. Because the topic is really very relevant for us as we move now. And as I mentioned in the email, we're doing more and more radical prostatectomy and even external beam radiation therapy because of individual screening that is moving forward as opposed to like a few years back. So it's time now. We don't have very large screening, but we have more and more companies coming because of the increased awareness to send their workers or the patients self-referring themselves. So I think we'll have it. And the other thing, just for your information, Scott, we're moving forward in our study, the MADCAP consortium. I don't know if you heard about it. The Men of African consortium, Men of African carcinoma of the prostate consortium. It includes centers, our center, 2 centers in Ghana, 2 centers in Nigeria, and 2 centers in South Africa. So we're doing a large study which is funded by the NIH because all of these centers has a twin collaboration with centers in the US. So we had a UO1 grant. We are in the 5th year, last year, where we want to do genome-wide association of prostate cancer, collecting clinical data, prostate biopsy results, because all of them has a cancer, confirmed cancer, and also doing blood draw for GWAS, trying to look at known genes of alleles of susceptibility and trying to find new alleles. And we also try to link the genetic finding to the aggressiveness of the disease. So for now, we have more than 2,000 prostate cancer cases and control. It's a case control study. And so, and doing this and what we found as we move forward is we have more and more localized disease. Actually, from the data I showed that are not published yet last November. Almost half of the patient had T1 or T2, which is something new, and that may be the effect of the study, where we have more people involved, aware of what we're doing and coming for screening, etc. So I think we have a long way to go in terms of diagnosing patients at early stage and offering them radical treatment. So a lot of to come in the near future.
That makes me very happy that you're doing that huge collaborative study. I look forward to learning from it.
Yeah.
One last thing, I just went to the chat, and Emmanuel, who's in Rwanda, had a great question. And he said, would you recommend the use of pre-biopsy MRI in countries where there is no image fusion facilities? And I would say yes, if you get good quality MRIs, because there are a few randomized studies of fusion biopsy versus what's called cognitive registration studies that showed similar outcomes, which was basically saying you use a fusion software, or you just get the MRI, and the MRI shows an abnormality at the left base medial, and on your ultrasound guided biopsy, you just take extra biopsies from the left base medial. You don't have the fusion facility. And the data suggests your yield of high-grade cancer is going to be exactly the same with the cognitive registration.
Okay, thank you very much, and we appreciated your time and your expertise, and we look forward for other session. And also thank you for IVU for making this happen. And we know it's just the beginning, and we'll have a long way to collaborate.
One last thing, or two last things. I think Josh videotaped this. You can send the link to people that may not have joined. Josh can also, Dr. Jallo has my email address. If anyone wants to email me with anything on future topics or questions, let me know. But otherwise, everyone be safe and well, and I hope to see you again.
Okay, thank you. Thank everybody for joining in. Thank you.
Thank you. Thank you.
Bye. Thank you.
Thank you.